Good afternoon and welcome, ladies and gentlemen. My name's Jack Ashby from the Grant Museum of Zoology, and I'm here to welcome you as host today and to introduce our speaker. Professor Oscar Della Pasqua is the chair of clinical pharmacology and therapeutics here at the UCL School of Pharmacy, and as well as that, he's senior director for clinical pharmacology at GlaxoSmithKline. At UCL, his research is quite a long list, but it includes the study of clinical drug design and how to predict the outcome or responses to medical treatments. As well as that, he teaches on the clinical drug design development course here at UCL. So he's extremely well placed to give us today's lecture, which is the powerful effect of placebos. If you could join me in welcoming Professor Oscar Della Pasqua.
Thanks, Jack. Good afternoon, ladies and gentlemen. Thanks for the opportunity to share with you some of the challenges I face, and I need to start my presentation with a disclaimer. I'm going to talk about lots of treatments and products here, and by no means I infer that their efficacy or safety profile is not what has been approved, but they are going to be used as illustration for the cases we will be discussing here. So, what are we going to talk about? I think it's quite a complex subject, and without having a clear picture of what you're going through, you probably get lost. So really the issue is, what is placebo effect in clinical research? And most important, how does it start historically? If you look at the use of placebo interventions over time. And I hope we get to the end of the presentation with a clear understanding what the placebo effect is today, how we interpret and handle it, and hopefully give you some ideas about the future of the use and the evaluation of placebo in clinical interventions. Now, as a clinician, you might really want to save patients from their illnesses and ailments, and you always come up with the idea that you have a wonder drug, but if you are working in R&D, in pharmaceutical R&D, what you face is the wonder what the drug is doing actually. You don't really know until you test it in large populations. Now, by the time you bring it to a wider population, on the basis of clinical trials, what you end up having is the assessment by regulators and agencies that judge whether or not it's efficacious and whether or not it's effective. And the debate is always around how better is it in relation to placebo. And this is really the conundrum I'm going through today with you, because historically, if we go back a century ago, there were no regulatory agencies, there was no procedures to actually define in a scientific way how drugs work. Today, we have to go through a pyramid of evidence that varies from animal research all the way to large meta-analysis where you're assessing first the efficacy and safety profile of a drug, and depending on the stage of the shelf life of that medicinal product, you're going to be talking about effectiveness. And you may have heard about organizations like NICE in the UK that define whether or not NHS can reimburse for the cost of those drugs. If you are in R&D, you are a stage earlier in that process, and you try to define whether the drug is significantly different from a placebo intervention. Now, that's nice when you look retrospectively at what is going on with the various options you have out there. The reality is, from an academic, scientific, and R&D perspective, we don't have that amount of evidence when you start developing a new drug. And what I would like to contextualize now is, why am I interested in placebo? Because we are trying to introduce quantitative methods based on mathematical, statistical, and biological principles that would allow us to make predictions about how novel interventions would look like in a broader population. In other words, we would like to simulate what the behavior of a treatment would look like in a much broader population before we deliver it to patients. And one of the components in that methodology is the placebo effect. We do look a lot at all the confounding factors and the determinants of the drug response, but ultimately, placebo will be an important component of that process. And I think today, from a clinical pharmacology perspective, what we have is a slightly different understanding of what we call treatment response. Everyone here has hopefully not been severely ill, but has undergone treatment. And what we normally look at is how your treatment looks like after, short-term, long-term, and define whether or not you have a favorable benefit-risk balance from that intervention. And what comes up from a lot of research in clinical pharmacology is that there are many players defining what you see as outcome of an intervention. And what I'd like to make very clear and hopefully come back at the end of the presentation is that the placebo effect is always there, whether or not you're taking an active medication. And I think this is an essential difference in the understanding how drugs work today, which has always excluded it's either the work of the drug, active ingredient, or the work of placebo. I think we come today to a much broader understanding of what's really going on, which means placebo effect may be present even when you're taking an active medication. And this is important because it has implications for the way we assess efficacy in official terms to ultimately approve the authorization, the marketing authorization of a drug, which is basically the difference relative to placebo or to a treatment comparator. And I would call that placebo response. So just to make it clear so that there's no confusion during the presentation, that the placebo effect is one of the components of the treatment response, and the response to a placebo intervention is called placebo response. So that's clear. What's response, what's effect? Yeah? And we'll be talking about the placebo effect and the implications for the assessment of treatment response in real life clinical research. So let's start with a few examples. I will show you some complexities that we have to face when defining the efficacy of new drugs. And here I have a treatment which basically starts at time 0 here, and clinically we define a responder to that intervention, any patient who drops in that clinical scale by at least 50%. As you can see, lots of patients do respond to the treatment. And perhaps I will spend 30 seconds, 1 minute of your attention here. How many patients in this trial were on the placebo arm? Any idea? Anyone for 100%? Anyone for 20%? Anyone for 50%? Well, all patients were taking placebo. Yeah? This is a typical trial in depression. This is major depression, and what you see is that the placebo effect is there, is huge, and it's maintained over the period of 3 months. So it's not suggestion in your mind. You are responding to therapy, and you're maintaining that effect throughout the course of the intervention. Yeah? So let's carry it on to the next problem. Someone said depression is a very challenging area. We don't really understand the pathophysiology of depression enough to identify drug targets that would alter the very basis of disease. We normally treat the symptoms. So let's move away from psychiatric disease, neurological disease that are complicated. Let's evaluate and put research efforts on drugs we understand the cause. So Fabry disease, a very clearly defined ailment where you have a deficit of it's a genetic disease actually, where you don't produce alpha-galactosidase, an enzyme which is important for various functions in the body. And what you can see is that this disease affects many organs and functions. And you'd say, I know the cause, and I can develop drugs that have to do with that mechanism of action related to the enzyme, in this case, and their product. So we solve the problem. Let's treat first those diseases, let's develop drugs for those diseases, and then go back to those we don't understand. And this is an example of an intervention in Fabry disease where we are looking at the pain components of that disease that are very important in that patient group. And you see that different types of measures of pain show a significant improvement over the period of 20 weeks. And you could say, great, that's the way forward. Now, the only problem, 20 weeks, not 1, not 2, 20. That was the placebo arm. So I have a treatment effect over 20 weeks that is not statistically different, but both clinically significant or clinically relevant over time in that population. Now, as you can see by now, we are really struggling to identify new targets and new molecules that do better than placebo if we apply the current definition of efficacy and effectiveness. Now, complicate a little bit more. what about those patients who are on the active arm? Because if placebo is present also when you administer an active ingredient, what are the implications for us? Now, as a clinical pharmacologist, we all talk about concentration or exposure response relationship. The more the drug you give, the more the effect. And you would expect this is a typical dental pain model. So basically, these are healthy subjects that need a molar tooth extraction. Anyone has had a molar tooth extraction? Just pull the tooth, and what you see here very clearly is that those patients who have had placebo after the anesthesia washes out have a huge response, because the vision analog scale, so this VAS, vision analog scale, is a scale for pain. The larger the number, the more intense the pain. 0 means no pain. Now, I'm not interested in the placebo arm here. I'm interested in the active arm. And what you see is that low concentrations of drug, which should have no effect, are producing huge analgesia. And that complicates our understanding of how doses should be defined when testing a new intervention. Now, a little bit more of the complexity that this offers to clinical research. This is another drug used for the treatment of migraine. And this is the safety profile. So not only efficacy is an issue when dealing with placebo, safety also bears an important role in defining the benefit-risk ratio. And what you see here in with this drug, I'm sorry, I think, yes, is that I have two important adverse events, anorexia and postural hypotension, which can be considered a very worrying set of adverse events if you're going to treat someone's headache. Now, the problem is that these two adverse events were on the placebo group. You don't see them on the active group. Now, if you think that you're blinding a study, so we normally don't know what the patients are receiving, now this type of information arising from placebo interventions create a lot of concerns and sometimes leads to the termination of the trial, because you may unblind the treatment at a certain point in time, but depending on the trial design, this may have implications for the validity of the conclusions you draw from the trial. So, quite difficult challenge we are here. Now, let's look at the funny side of it, if you will. This is a list of, and the publication will be referenced later on, is this example of metoprolol used for hypertension, really, where erectile dysfunction has been noticed as an adverse event. And what they did here, they randomized these patients to different groups where what they're trying to do is to understand the impact of information on the ultimate result of the trial. And what they did, some patients were told that they would receive a certain randomization ratio, so they would take the drug, but they were being assigned to a trial where the number of subjects taking the active drug and the number of subjects taking the placebo arm was different. And what we see is that in group 1, so basically group 1, let's read here, group 1, full information. They were told that there was adverse event and there might be placebo versus active. In the second group, they received partial information. They said, well, there might be adverse events, but they didn't tell which ones. And in the third group, they didn't tell anything specific about male erectile dysfunction. And what you see is that the number of events that appear in that trial is proportional to the transparency in the information you're providing. So you react to what you're told. Yeah? The Hawthorne effect. Yeah? We're going to discuss that later on. And that's very important, because the more we tell, the more we look at transparency in clinical research, and the more patients look for internet, for information, the more you are feeding expectation around what might happen in that trial, creating quite a lot of, let's say, difficulties in the interpretation of those data. So how complicating is that? So this is the last slide on these case examples to illustrate that this Parkinson's disease, so very objective issue, we're talking about motorial deficits, and they have been mapped using imaging technology, PET, so positron emission tomography, for those who are not familiar with the technique. And what we see, these patients were all receiving placebo. So I haven't included here the active arm. But what's important is that there is a dose response to the effects of those treatments based on what I told the patients. Here, I told them that there might be 25% chance you receive the active treatment in your trial. This one, I told you might have a 1-to-1 randomization, which means 50% chance of receiving the active ingredient. The third one, I have 75% chance of receiving an active ingredient. Yet, all treatments were placebo. So I was deceiving those patients, technically speaking. Yeah? So, and there is a statistically significant difference between this effect and this effect. Now, conclusion is, I could, technically speaking, approve placebo. So actually, we could, based on this exercise, we could approve placebo because you can create a dose response curve and separate placebo from placebo. And I'm going to use this, this joke because it's an important, let's say, sarcasm to make sure we understand the difficulties we have in clinical research. Now, if the way I inform patients, the way I design trials, the way I assess those measures of efficacy or safety are altered by your understanding of the trial, I really have a problem. Now, what can we do? I think we need to, first of all, scope out the problem. And as I said, I'm talking about the issues from a clinical pharmacology perspective. And I think we need to understand we need to address placebo effect if we want to find new innovative medicines. We need to do that in a less empirical manner. It's too much of trial and error. We already learned the implications of that trial and error approach. And what is missing really? We need to do more to understand placebo as a biological phenomenon. It's not a psychological phenomenon. It has psychological components, but it is a biological phenomenon. Yeah? And I'll show you a few details later on. And I think most important for me in my field is that from the moment I understand the substrate that determine the placebo response, I will be able to start predicting placebo behavior in a treatment and possibly understanding better the real net effect of active treatments, which is now quite challenging. So, take a step back. Where are we now? Where it started? And for those of you who like history, I thought it would be interesting for us to look back and understand why we are where we are today and how placebo evolved in terms of its role in the assessment of efficacy. And it starts in the Bible, funny enough, in Psalm, and it means really what's written here. I will please the Lord in the land of the living. And it's important for you to realize that placebo has a counterpart. So here's about the benefits. There's also the negative side of placebo, which you will hear sometimes being defined as nocebo. Very few people use that nowadays. So where does it start? Well, since we are in the UK, I thought it would be interesting to look at some of the history of the use of skulls as the starting point for interventions. Elizabeth I and other kings in England have used, basically, crushed the skulls and some other excrements and other things together to make, let's say, a clear therapeutic intervention for their diseases. And that goes into the use of blood. Well, we had purging. We had, well, we have today, actually. Go to Asian countries where turtles, snakes, tigers, rhinos, and so on are used. If you go to the other side of the Atlantic, you might find ants. This is a typical liquor where you have giant ants being basically decocted in that liquor, and it's supposed to cure lots of things. Now, turmeric, crystals, and you name it. And what I want to show you with this is that placebo has changed shape over the years. Placebo has changed sources over the year. You start with human material, so the warriors, the victims of aggression and violence were supposed to provide you the spirit of life, and therefore they were used as source of efficacy or treatment improvement. Then you try to remove your own blood as a potential intervention, and you go on into animals, into plants, into minerals, all the way to chemical entities. Now, as you can see, placebo has changed shape and source over the years, but it still remains the same thing. And what is that same thing? The meaning of the intervention. And I think I would like you to take home from this whole discussion only a single statement. Placebo is the effect of meaning, no matter how it's delivered. Yeah? In other words, your understanding of the intervention. And I could, again, I am a clinical pharmacologist, I am not going to touch upon other types of procedures and practices, but the meaning of the intervention alters the outcome of the intervention. And that applies to anything from surgery all the way to, let's say, yoga. Now, so what? Great. It works. It works to a certain extent, and I will not debate that. It's not the scope of today's discussion. The point I'm trying to make, if it works, whether short, a lot, or long enough, it's not really the issue. The issue is how do I separate that effect from treatments that I'm trying to define in a standardized scientific manner. And for me, it really starts to become clear if we change the way we look at placebo. Change the way we look at placebo by looking at it as the meaning of intervention. That requires us to pay attention to a number of issues. They are technical, not interesting for you at the moment, but they are required if we want to move ahead with the field. And I will start saying that to do a better job with placebo, we need, first of all, to define where it's coming from a biological, physiological perspective. As we have done with drugs. 20 years ago, foxglove, digitalis, we didn't know what was actually working, but we made use of it. Today, we know what digitalis does, and we know the chemical structure of the compounds that are present in foxglove. Now, why aren't we doing the same with placebo? We need to understand where it comes from, which structures, which components determine its behavior over time in a patient. And this is important, not only because it's scientific knowledge, but because today's definition of benefit of an intervention has changed. Drugs are working at a cellular genetic level, but when I go to regulatory agencies, when I go to clinicians, when I go to patients, what they want to know, do I feel better? Do I get better? And the therapeutic aim of a treatment is at a much higher level, individual societal level, which makes this jump quite a challenge already for our drugs, let alone if we ignore what the placebo role is in this. Yeah? So we need really to do something different about it. So what can we do? Just summarizing very briefly what we went through so far. So there's a positive and negative effect of placebo. We have an issue with the way the experimental design is set up. So it will vary depending on which experiment you're doing. And you also have to realize there is a dose-response curve, as I indicated before. Patients who take more placebo will respond more than patients who take less placebo. And they are cumulative over time, and they might have peaks, carry over all the statistical issues that we normally try to address in a standard clinical trial. And the situation is so dramatic, and we have done, and there are published data there, that if you increase the number of tablets you give someone on a placebo trial where you're talking about dose escalation, you see an increase of the effects, both positive and negative. Let's think of diarrhea. So someone might have diarrhea with one tablet. You might have more diarrhea with 2 tablets. And that's the issue we are facing here. So many publications have tried to disentangle the meaning from the pharmacology. And what we see here is a very nice publication, older one actually, where many people have criticized the study design. Let's not go into the technical details, but the concept behind this publication, which was based on carisoprodol. It's a myorelaxant drug, basically to relax. And what you see is that depending on what I tell the patient, whether it's relaxant, stimulant, or no information about the mechanism of action of the drug, I get a different level of the drug in plasma. So I change the metabolism of the drug. So this is a true physiological change. My liver eliminates the drug more or less fast, depending on my expectation about the mechanism. Yeah? So this has a very physiological explanation, very easy, not get into details. But the interesting thing here is that depending on what I have told the patient, I counteract the pharmacological effects of my drug. And this is shown here. My placebo effect here, so the triangles are a stimulating effect for the scale defining relaxation and tension. And you see that the placebo effect is not much different from the drug effect, depending on what I'm telling. Actually, it's even higher than the drug effect, depending on what I'm telling. So it changes the pharmacology of active compounds. And that's where I start getting worried. As a clinical pharmacologist, I always thought what changes drug effects is pathophysiology, is mutation, is genetics, all of these issues that we probably have come across. I never really thought we would be in a situation where the information alters not only the placebo, but also the pharmacology. So this has been tested and retested many times, and they did a very nice exercise where they basically given hidden treatment. The patient didn't know he was receiving the drug, as opposed to the traditional treatment. And what you see, just to give you a very clear indication, these are all opioids for pain, post-surgical pain. And what you see is that if I hide the treatment, i.e. the patients don't know they are receiving those drugs, what will happen? The pharmacological effect disappears, basically. And these are all active treatments. Well, again, I am modulating the response, meaning your homeostasis, your various organs and systems are interacting with the mechanism of action of the drug and modulating that response based on your expectation. Some people have said, well, you know, that goes away very quickly. It might be. That is a very temporary effect. But in some other areas, this can last for long enough to mess up the conclusions you can draw about the intervention. Another example, change the color of the tablet you're delivering, and you change the effect. Yeah? Give a red tablet to someone who wants to sleep, an elderly, normally coming for insomnia. If you give a red tablet, the person may not sleep because red is stimulating. Give him a blue or a white tablet, fantastic. Even if both are placebo, you see that this is really not simple to address. Now, what's the basis for all this? Now, it started with the evaluation of pain. Where do people get that feeling of analgesia despite very clear potential pain for symptoms in this case? Well, it comes from endogenous opioids. This has been done for a lot of time, and this also applies for acupuncture, partly, yeah, or back pain, or whatever you want to look at. But there is a component based on endogenous opioids. Now, that's not enough to explain all the treatments and interventions where we see placebo response. So opioids are important in pain response. But what about the other types of response that might be from immune response to mood, where opioids are not really relevant to? And what you see is that there's quite a lot going on, including cognitive and social variables, which perhaps are too far for us to get into details today, but they do get on the way when you're trying to really put everything together. It's a puzzle, really, yeah? And for me, I think I have to bring that back a little bit closer to pharmacology to close our discussion today, really, is that it does have a direct mechanism which has to do with homeostasis. It has indirect mechanisms which are basically the consequence of patient expectation and behavior around the trial, as well as the interaction of both effects mentioned above that lead to a potential synergy between quotations about what they actually do during the trial. Now, the subject has boomed over the last few years, and there are books and books and books talking about placebo. If someone's interested, you can look at any of them, but the bottom line is all of them have not been conclusive about what to do with it. I think it's important we understand where they're coming from, how large their influence is in the assessment of benefit and risk, but we need to do a little bit more than that. And what I'd like to basically share with you is that the message really is the substrates that determine the placebo response are not necessarily the same receptors on which the drug actually acts, so the active drug actually is working on. So you have different pathways. So in red, for example, is the one that they have mapped for depression using fluoxetine. The blues are the ones where, the reds are the placebo, and the blues are the ones with the active ingredient. They have done that for another series of drugs where they show that placebo and medication responders have different imaging patterns in their brain using quantitative EEG accordance. And you see, again, non-responders look much closer to each other than the responders to active and medication. Don't bother too much about the details there. I think the key message here is there are different substrates in parallel sometimes converging, that will define what you then see as outcome of an intervention. So, if I want to use that in my technique or methodology, I have to bring that into some equations, which someone is interested, we can talk after the presentation. But the main thing is there is an interaction which leads to response, and that interaction is biological with or without psychological and social components in it. So we're basically getting to the end of the story, which is, does it really matter to patients where placebo is coming from? I think ultimately what we are interested, whether you are a clinician, a regulator, or a scientist, can we bring improvement to patients who are ill, and can we eventually cure, not only improvement, but cure their conditions? And what we see is that the term improvement is more than just one or two factors. It's actually a combination of factors that ultimately determine the size of what you observe in a trial, one of which is the placebo response. And I think if we put a little bit in context, this is what I would say the placebo response as part of the overall improvement that you observe in a placebo treatment arm in a clinical trial. And as you can see, we need now to start looking at those things more carefully and quantify them if we want to make clear statements about what the actual active ingredients are doing to those patients. Now, I started my presentation mentioning that my understanding as a clinical pharmacologist of today's response in an intervention is a combination of factors that needs to be quantified and factored together whilst making predictions about the benefits or risks of an intervention. And I showed you that the placebo effect will be there whether or not you are receiving an active treatment. So the placebo response may contain the placebo effect if you are on a placebo arm, but the placebo response, the treatment response, will contain the placebo effect even in those patients who are receiving active treatment. So I hope I gave you a good a range of issues and some food for thought about what this will represent to the future of research. But I guess the main conclusions we could draw from here is that so-called the sugar pill is an active treatment. So I think that's the important thing. A placebo is not inert. It has action. And it may have action on different pathways than the active ingredient. It's not a random effect. Placebo is there, it's true, and it's proportional to the intervention. We should think that physiologically it will produce things that the active treatment will not do. So functionally they are not equivalent to the active response. Most important, I think, and this is something that will become field of research in the future, is really the information. How much information do we provide patients? We are all in the area of information, transparency, but we are paying the price of that. And I'm not saying omit information for patients, but we need to understand how to deliver that information because it will affect the measures you are collecting in the experiment. And we need to stop just putting placebo in a trial for the sake of comparing it to the effective treatment. We need really to look at it in itself as a subject of research. So we need to take a step further and really define what are the mechanisms and map them the same way we have done for active ingredients. Thank you very much for your attention.
Thank you very much indeed, Oscar. That was a fascinating talk. We do have some time for questions, which is great news. If you do have a question, raise your hand and I'll point to you and wait for a roving microphone so that people listening online can hear you. There's a question down the front.
I was glad to see in your last but one slide that you did include regression to the mean. And there are pictures like your antidepressant one where people get better on placebo and active treatment and also get better on no treatment at exactly the same rate. So I wondered whether your antidepressant one contained people with no treatment?
No, usually not.
So usually not, no, because you can't tell the placebo effect by comparing the active arm with the placebo arm. What you've got to do is compare the placebo arm with no treatment.
Yeah.
When you do that, you usually find that the effect is quite small, not big enough to be useful.
Sure.
So it's mostly get better anyway effect, not placebo effect.
Well, thanks a lot. I think it's a very important comment. The problem we face here are the ethics. We cannot have identified and diagnosed a patient with depression and do nothing about it. So that's the issue we face. Science may be very objective in indeed identifying options for you to disentangle the problem, but practically that's not feasible. Therefore, we want to apply models, mathematical, statistical, and biological models that would allow us to evaluate those conditions which cannot be defined practically because of ethical reasons.
Well, I think if you can give a placebo ethically, you can give no treatment ethically too.
The GMC has a different opinion on the use of no treatment. There was a question over there.
Is there a question over here?
Just what you mentioned about the difference in colour of the pill affecting people differently. Have anybody done any studies on differences in that between cultures, depending on what the colours symbolise within the culture, that kind of thing? Probably not. But
I'm not really aware, but definitely we know that different cultures have different perception of the impact of different colors. We know that. And we have done a lot of trials in US, Japan, Asia in general, and we do see what we call country effect. And partly of that, of course, normally we have the same product being used across different countries, but I haven't seen anything really comparing across the cultures, but we do come across country effect, and usually they are culturally determined more than genetically determined.
is it more to do with people wanting different amounts of information? Because obviously in the West now we need to know all the information, so if you don't get any, it's going to be worse. I don't know whether somewhere else there might be not so much of a difference.
I think in today's reality, I think it's more the interaction between the physician and the patient. I think patients are curious normally. Usually you would be curious about what you're being offered in a trial. The reality is how you perceive your physician. There is a different cultural value about the role of physician in Asian culture and in Western cultures. You actually debate with your physician whether you're going to take a drug or not. That's probably not going to happen to the same extent in certain cultures.
I guess one great value of placebo is the absence of side effects. Are there any side effects of placebo? Any
Yes.
after effects?
Yeah, so that's I think the problem. So are there side effects on placebo? Please, this is the important thing. Placebos do produce side effects, depending on the information that you're providing the patients. As I showed you, anorexia. So if we said there might be risk of anorexia, you end up seeing anorexia in that treatment. But the most important thing is that sometimes by not treating the patient, so the placebo should have no real therapeutic value over time, that's the assumption today, you may see complications of the disease. And what becomes very challenging is how do you separate an adverse event due to the treatment from a complication of the disease. And what you see really in many trials is complication of the underlying disease because you're not treating the patient. Yeah? So it's difficult to separate, but they can produce adverse events. As I showed, anorexia as an example here. They can be serious and can take patients to hospital. Now, even if you don't tell them, and which you cannot do in a randomized trial, they would still experience adverse events. Usually they are mild. General adverse events in placebo are mild, but there are examples of severe adverse events. And again, as I said, we cannot omit the information. Today's standards for clinical research impose us to tell patients what the risks are of the intervention and tell them they might receive placebo. How they factor, how they work that information varies from patient to patient, depending on how much they absorb and work on those bits and pieces of information.
There's a question behind you.
Absolutely fascinating, thank you. Is there a correlation, positive or negative, between an individual's placebo response and their drug response?
Yes, thanks. I skipped that slide. So there has been an attempt, well, if placebo is a nuisance, let's get rid of it. So what you have actually seen, and there are many publications in the field, you basically run a trial over a period of time, 2 weeks, 3 weeks. Everyone receives placebo. They think they're taking the active drug, but it's placebo. And all those who respond to treatment we say, well, you are a placebo responder, I get rid of that group. Solve the problem. Now, was it true? No, what happens? All patients who are placebo non-responders and follow on the treatment with the active ingredient are less likely to respond to the active ingredient. So there's a strong correlation between the placebo effect size, how big your response is, and the active treatment effect size. Yeah, so they are highly correlated. Which means, again, if I exclude those patients, I need larger trials to statistically prove the benefit of the intervention.
Thank you very much. I'm afraid that is all the time we've got today. Thank you all for coming. Thank you for your questions, but mostly thank you to Professor Oscar Della Pasqua.